This week on the BackTable podcast.
Portal work is probably one of the most fun work. Sometimes can be one of the most challenging. It's one of these things in IR, then, there's a lot of overlap with other specialties. There's nothing wrong with it, but it just sometimes can frustrate some younger people when, it's like, oh, I would like to do PEs and DVTs, and then these other specialties are doing it in PID and or even, ablations or, nephrostomy access for lithotripsy and gastrostomies. And you can go down the line, even ports, So, there's most things we do. There's some other specialties that does something similar to what we do. Portal interventions is something that we own as interventional radiologists, and I think it's good to be really well-versed in it as an interventional radiologist to provide value. That being said, if it's something that is you're not comfortable with, it's okay to ask and reach out to other centers or other people around the country who do.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com.
Medtronic offers a comprehensive portfolio of products for the embolization of the peripheral vasculature. Learn more about the MVP microvascular plug system and Concerto detachable coil system at medtronic.com/embolization.
This is Aparna Baheti as your host, recording from Tacoma, Washington. Today, I'm honored to be joined by Dr. Saher Sabri, Chief of Interventional Radiology at MedStar Health and Division Chief of Interventional Radiology at MedStar Georgetown University Hospital. Dr. Sabri, welcome, and thank you for coming on the podcast.
Thanks, Ali. Thanks a lot. Really appreciate it to be back on the BackTable podcast.
Before we get into our topic, would you mind just telling us a little bit about the training program at MedStar for the trainees?
Yeah, so our training program is based at Georgetown University Hospital and Washington Hospital Center, both part of the MedStar Health System. We have usually 4 PGY 6s or 7s, have an integrated residency and independent residency. We take 2 integrated a year. We be complemented with 2 independent a year. Between the 2 hospitals, we cover a wide range of procedures. We have, 2 of the largest hospitals in the DC and the DC metro area, and big transplant center, oncology center at Georgetown, and a big, vascular center and trauma center at Washington Hospital Center. So a lot of complementary work. We're a large health system with 20 plus interventional radiologists and ample opportunity for conferences and collaboration across multiple sites in the community and academics. So it's a pretty comprehensive training program, and we'll love having you guys join us.
Thanks for that. Okay, our topic today is BRTOs, PARTOs, and combination BRTO tips. We're building a little bit on what Dr. Emmett Linsky talked about in his tips tutorial, and he suggested that we interview you as one of the luminaries on tips plus BRTOs.
It's kind.
To start, just walk me through how you do a regular BRTO or PARTO. Just walk me through your approach, what you use to occlude, what sheets you use, what kind of access you use.
Yes, I think that, the starting point is deciding to do the procedure and when to do it. And I think reviewing the imaging is the most important aspect of it. I spent a lot of time planning for the procedure, reviewing the imaging, and, like everything we do in IR, but particularly for this procedure, you need to look at the shunt, study it well, know that you definitely have a splenorenal or a gastrorenal shunt, connecting to the expected location of the renal vein. By just knowing that, and just some gastric varices don't have, splenorenal shunts, you have to kind of know that, know the size of the shunt, know the location, how close it is to the IVC. So generally speaking, I plan to go IJ or femoral based on its how close the shunt is to the IVC. The closer it is to the IVC, I try to go femoral. The further it is into the renal vein, away from the IVC, the U-turn becomes, an easier U-turn to make. I'll go IJ. So these are just a quick starting point. And sometimes, things are in the middle, you can do either. And then, the next step is, which of the 2 techniques or 3 techniques you can use. We're trying to kind of move away from when we describe it as a general concept, as opposed to TIPS or sclerosis or, endoscopic, to call it RTO, Retrograde Transvenous Obliteration. It just makes it easier, just like a big term that encompasses BRTO, PARTO, and CARTO. One uses balloon, one uses a plug, and one uses coils. respectively. Or, sometimes we use a combination of these two. But, the concept for when we compare it to other techniques, it's good to use, we try to call it RTO, trying to kind of push that term. But, generally speaking, they're interchangeably. So they can be used interchangeably. So I usually like to use BRTO. That's what I've did most of my research on and pushed that early in its adoption almost 15 years ago in the U.S. And of course, it's been, implemented and used extensively in Asia before, we kind of caught wind of it in the U.S. So basically what we do is once you get access, I try to go femoral, for example, then you go with a Simmons or a Cobra catheter, you get into the renal vein, and then from there, you advance the sheath, and the sheath size, usually depending on the balloon you're going to use to do the occlusion. So generally speaking, and 8 French is good enough size to do, like an Ansel or any type. You can use one of these tip deflecting sheaths, for example.
Mm-hmm.
These are good option. Like there's several on the market, Destino, Aptus, and such. So you get that access with glide or glide advantage, and then you can use a Rosen or something to kind of get yourself anchored into the renal vein, and then you use just a regular Compi or Bernstein or MPA catheter to select the shunt by pulling back and then wedging into it and advancing a wire up there, usually a regular glide or glide advantage, and then, put the catheter up. And then the idea is to have the wire go and loop into the shunt itself. Sometimes it can go into a small outflow vein, like a phrenic vein off the shunt. That is okay because it kind of helps you anchor. And then you can, through that sheath, which usually sits at the origin of the renal vein, it doesn't have to go all the way up into the shunt if you use the BRTO technique. Then you can just advance the balloon into the shunt. Several balloons in the market. There's a Python balloon, BioLight Medical. There's a Boston Scientific occlusion balloon. There's a Cook occlusion balloon. You can use a Fogarty balloon. There's several options. You can go there. So you go up into the shunt. You try to size it to match. So, these balloons are usually go up to 14 millimeters or so.
Mm-hmm.
Sometimes the shunt is much bigger than that, but then you try to find an area of narrowing into the shunt. Usually it's right before it meets the renal vein, is where you can inflate the balloon. Even if it's somewhat undersized, you can just pull it back to wedge it against that bend or natural kink that happens at the base of the shunt before it goes to the renal vein. Once you do that, you inject to the lumen of the balloon to confirm that you're occluded fully. And once you do that, then you can go to the next steps. So that's basically the first way of doing the occlusion balloon technique. Now, if you use the PARTO, the plug-assisted occlusion RTO, then you need to advance the sheath into the system. So you have to spend some time with a catheter and a glide or glide advantage to go into the shunt, have a wire there that is stiff enough. You can use an Amplatz with 1 cm tip. You can use a Rosen, and then you advance your sheath with a dilator into the shunt. So there's that aspect of it that, if it's not a favorable angle, there's that issue that could happen with rupturing the shunt. So, this is one of the disadvantages of a PARTO over a BRTO. You just need to advance the balloon. Just a couple of things to consider when people deciding which of the two to use. And then, for the PARTO, you have the sheath, then you just put a plug, you size it, you go up 20 to 40% oversizing over the shunt, and similarly, you pull it back to wedge it. And once you have that, now you occlude, and then you pass a catheter and a wire beyond the plug. And then from there, you inject to confirm that you're occluded. So the treatment you're going to do is going to be beyond the plug or beyond the balloon up into the shunt. With the balloon, it's through the balloon lumen. With the plug, it's through a catheter that is on the outside of the plug. You can place that ahead of time, leave a wire, and then put a wire, and then deploy the plug. And over that wire, you can advance your catheter. Or if you end up using a bigger sheath, you have a favorable access, you can use a bigger sheath, leave a catheter there, and then put the plug next to it, and then pull it. That requires you have to kind of do the math and see that's, a catheter is 5 French, you're going to add to it, that's a much bigger sheath. So the wire is enough usually to pull the plug, and then over that wire, you can go. Trying to negotiate, once you deploy the plug, try to negotiate past it up there. It may sometimes it's easy, sometimes it's not. So it's better to leave a wire behind and then go over that wire with a catheter and do the work from there. So that's the basic concept of access, and we can talk about the next steps afterwards.
How far into the shunt do you want your embolic catheter to be?
Yeah, so I think, the first step is to confirm the occlusion. And I think I can't stress that enough. Before you start embolization, you need to make sure you're static, you're stagnant, that your plug or your balloon are actually completely occluded the shunt. So now all the contrast you inject is not going to the renal vein, it's just staying in the shunt or propelling retrograde against the flow up into the varix with contrast. So if you confirm that, then you can start with the next step. But if it is not the case, then you just need to kind of adjust what you're doing, just the size of the balloon, the location of the balloon, pull back on it. And if you have the plug, it's not occluding well, the concept with the plug is to use gel foam, thick gel foam to kind of create that coating around it to occlude the shunt. With the balloon, you're relying primarily on the balloon to do it. Now, just before telling you of the catheter, there's something that when you inject, you see the contrast go up a phrenic or a collateral that is just, it's not going back to the renal vein, you're occluded, but it's escaping through other collaterals.
Yeah.
So the way to navigate that piece is to couple of things. One is to advance your microcatheter through the balloon as high up into the shunt as possible. So you just, any wire can do. For a catheter, it has to be a catheter that could fit through the balloons. The balloons, the lumen of them is small. It's 035, not 038. So you're limited with your options for the microcatheter. You can put through an occlusion balloon. So it's some of the neuro catheters like Echelon and Rebar, and some of the 2O, for example, Prograde, or, so these were, it's better to be a 150. So the taper, you don't reach the taper, because most of the regular microcatheters you used, they taper to 2.7 or 2.8 at some point. And so it doesn't fit through the balloon. So test it on the BackTable before putting the balloon, make sure it fits. But the couple of the catheters I mentioned could work well. So so then I do that with an 014, any 014, select choose your flavor, or 014 or 016 wire, and then you just go up, make loops inside the shunt. Sometimes you have to hit some bank shots, like make a couple of loops before you find the outlet to go to the next loop, and spends as much time as possible to go as high up as possible into the shunt. Once you're there, usually you're past these other phrenics and collaterals, and then you can inject the sclerosant. Sometimes you just keep falling into this phrenic, collateral, then you can coil it. Just coil it, and then so flow doesn't go there. Now the injection goes the other way. So that is okay to do. The other thing, you can just gel foam that, or once you inject sclerosant, some of it will go, just give it some time till that collateral is dead, and then the rest is going to go up into the shunt. Yeah. So generally speaking, with a PARTO or BRTO, I try to go up as high as possible with the shunt with a microcatheter. Now, if you're using a 4 French or a 5 French, next to a PARTO, be very careful about putting the catheter, the 4 French or 5 French catheter too high up in the shunt, because you can rupture that shunt. So I would be very careful with that. That's why I usually prefer BRTO. I've seen ruptures, and they're not good. If the rupture is close to the renal vein, it's usually okay. Just leads to technical failure, because you just, lost your chance to fill it. But if the rupture is higher up, it can be intraperitoneal or intraluminal, and that could be disastrous. So be careful about putting a 4 or 5 French catheter more than a few centimeters, high. Many probably would say, oh, I've done it, yeah, but if you've done more, you're going to run into issues. So I would say try not to run it too high. If you need to go, then use a microcatheter. If you're using a PARTO and you already have a 4 French catheter, you can put a 2.8 catheter in it, like a high flow. And so you can, if we use a gel foam, you can put something, thicker. With the BRTO, you cannot use thick gel foam, because you're injecting through a smaller microcatheter through an occlusion balloon. So that's one of the, downsides for that. So for that BRTO, what we usually use is a sclerosant, which is SDS, sodium tetradecyl. And the formula for that is usually use the SDS 3%. And then we use a 3-2-1 concoction, basically. So the 3 is air, 2 is SDS, and then 1 is lapidol. That's in cc. So you usually start with 6, 4, and 2. Make your first foam and start injecting through the microcatheter. Usually, in general, volume-wise, you end up getting around 30 cc. Sometimes huge shunt can take up to 40 or 50 cc. If you're injecting only like 5 or 6 cc, then you probably have not filled enough. So usually that's the volume that is usually needed. And I like that, sclerosing, because it can actually sclerose and, cause endothelial damage. Gel foam, when you use for PARTO, you need thick gel foam to have it to sit on top of the plug to make it stagnant. And then afterwards, you can switch to STS mixed with gel foam. So that would actually be good. But you have to use the gel foam with it to make it stagnant. Because if you just use the STS without any gel foam, it may just keep leaking through the plug. So you have to mix it with gel foam. So for that, it may clog the catheter and such. So these are just few technical things that when you choose between the two to use.
So if you're doing a PARTO and you inject gel foam, you create stagnancy over your plug. How do you mix your STS plus gel foam concoction?
Yeah, so after that, I personally I do not use that technique a lot. I like to use the BRTO. But if that's the case, I would just basically eyeball it. I've done it several times, of course, in other settings. But you just eyeball it. Sometimes I alternate. I'll use STS like 5 cc, then I'll give like 3 cc of gel foam. Then I keep alternating between the two. Sometimes they all don't sit very well in suspension, so you can alternate between the two. But yeah, I would add 2 or 3 cc of gel foam to that concoction of for example, 642. I'll add 2 or 3 cc of gel foam and go from there. And then, but yeah, sometimes you just can alternate between the two, which is fine because it just can become messy with all of these together in the same syringe. But yeah, and then the next thing is your endpoint. I'm sure that's your next question, right? Like when do you know you injected enough? I'll give you the chance to ask that question.
Yes. What is a reproducible fluoroscopic endpoint that newer operators can look at and say, okay, I'm done?
That's a brilliant question, Ali. Thanks for asking me. I was not expecting it. So I would say that you need to study your shunt very well ahead of time. Try to get a sense of, where the varix is located. It's in the fundus, most likely. That's what we usually do it for. And then if you have a sense, try to figure out what the inflow is. It's not that easy to find, but if you can try to kind of locate it ahead of time, that would kind of give you a sense of where the inflow is coming from. The more you study these, you can try to figure out if it's short gastric, it's posterior gastrics or not. But in general, usually when you inject the sclerosant or gel foam, it's going to go up to just under the diaphragm, and the next thing is going to happen is going to start going down towards the varix. So it's good to do some obliques, a little bit of an LAO to kind of, separate them so you can look in a little bit from the side to kind of make sure that you're not missing when sclerotin starts going downhill. Basically, it just goes all the way up to under the diaphragm, then starts going down. So as it starts going down, that's when the varix is. So if you have not seen that motion, this means you're still going up. You have not filled the varix. You're still in the shunt. And it could look very tortuous and we're like, oh, look at all these beautiful varices. Actually, you're not. So unless it goes all the way up, that's basically just outflow. The shunt could be extremely tortuous, can look like varices. You need to get the sclerosant or the gel foam in the varix itself. So you go all the way up, and then once it goes up, starts going down. And once it goes down, you have to be now very careful. If you keep pushing a lot, it may just go into the splenic vein and from there into the liver, into portal vein. So, you keep pushing till it goes up. And once on your oblique, make sure you're not missing something, behind you coming and you're missing it. Then you oblique. And once you start seeing going down, then slow down and watch it and can propel on its own, give it like 20 seconds or 30 seconds, just watching it, make sure that it's not just keeps going on its own because it has some momentum as it goes downhill. And then you can just add a little bit of small aliquots to make sure you fill the varix. And if you can see filling of the inflow vein itself, that's perfect. If you cannot, you just see the varix itself filled, that's great. Now, some would say, oh, sometimes I only put a little and I just occluded the outflow and that took care of the whole thing. Yes, there are certain types of shunts that are straightforward, just one inflow, one outflow. By blocking the outflow, that is enough. And it may occlude and you may get lucky and there's no other outflows that it's going to recruit. But you're going to run into a lot of these. There's several types. There's A, B, C, and D. The A are the easiest one where there's like one inflow, one outflow. If you just block the outflow with a little bit of gel foam and a plug, you can get a CT later and looks beautiful. And you're like, yeah, why do they have us, go all the way up and down? But the reason for that is if you do that as your endpoint, you guarantee that even if you get a more complex type, which sometimes it's hard to figure out ahead by imaging, you guarantee that you're going to obliterate the shunt and prevent it from recruiting other outflows that, that can actually recanalize. And that would be a major issue and it becomes harder to treat afterwards.
Okay. It seems like a pretty straightforward endpoint. I'm sure it sounds straightforward when you're describing it, but I'm sure in real time it's a little stressful to say, oh, did it flip or did it not?
I agree. I think I agree, Al. I mean, it sounds easier on description, but I still struggle with it sometimes, and you just look at it, it's like, did it go down or not? And it just, it's not always as easy. One thing that I reviewed a bunch of cases from before and just looked at them, and, it's like a general kind of rule of thumb I'm using now, that where the balloon is or the plug is, usually it's a couple of centimeters above the renal vein, right? And then
Mhm.
the splenic vein is usually a little bit above that. So what I would say is, if you go from where your balloon or your plug is, draw a line, and then you draw a line at the topmost portion of where the sclerosant went. If you go halfway through between these lines, if you get to the halfway point between the lines, I
Yeah.
think you've done enough, on the way
Okay.
down.
Okay.
So that is, I would say, usually if I see it go up and then come down halfway, then if it goes all the way down to the level of your balloon or your plug, then you probably have pushed it too much. Unless you really manage to get your balloon way up, which is, you don't usually need to, or you plug that way up, you don't need to.
And then since you are a BRTO guy first and foremost, do you do this single session and leave some coils behind, or do you send them up with a sheath overnight and then bring it back?
Yes, I mean, when we started this, many years ago, we used to keep the balloon because we're not sure what we're doing. And then we started with overnight, then made it 4 hours. Now it's rarely do this. I would say most of the time you end up coiling through. So basically through the microcatheter, we have big coils now go through microcatheters. You can just coil the whole shunt and then deflate slowly. While you're deflating, you see the coil move, you can put the balloon up, wait another half an hour, then deflate it. And that would work fine. So that's basically, some people call it PARTO, but it's basically balloon assisted, with coils at the end. Sometimes you can use coils alone. So, just, people can put exactly using the plug, put coils, and then some gel foam to stagnate and then go next to it. Exactly like the plug, but instead of putting the plug, you just use the coils. Now, there is one technique that I think can work very well, which is using a guide sheath with a balloon. So there's some neuro basically for flow diversion. So there are guide caths with balloons on them. So Stryker makes one, and, Concentric Medical, Mercy Balloon. So there's a few on the market that, they're kind of a little falling out of favor. They're not used as much by neuro guys, but if you can get your hand on one of them, the inner lumen is 8 French or 9 French. So you can actually put a plug through it. So you can use it as a balloon. It's a neuro product, so it tracks beautifully. So so you can take it up into the shunt, inflate the balloon, and now your lumen is big, actually. It's a 9 French, and then you can put a catheter through it, a 4 French or 5 French catheter, and then through that, you can put a high flow catheter, do whatever you need, and when you're done, you can put a plug and some coils, so you don't need to use just coils. Yeah, they're expensive, significantly more expensive than other balloons, and you may not find them easily if you don't have a neuro section and such. So it's not used as much, but I use that for really big shunts. When I try to use a balloon, I cannot find the balloon to actually occlude it, then I use that because that balloon can go bigger, or at least I can push a plug, like a 22 plug in there, and just, 22 plug, and just, push it in there, and then, to get that. And I give credit for Dr. Wildside, who came up with this idea, at some point when we were kind of experimenting with these.
Oh, so many ways to approach it. That's what's one of the great things about an RTO, right?
Yes.
Okay. Thank you for giving us that brief overview of how you run through the case. That was extremely helpful. So now I want to talk about the topic at hand, which is combined TIPS and BRTO. So give me like the classic patient that you see where you would start with a primary approach combined TIPS RTO.
Yeah. So generally speaking, I use RTO alone in patients who have isolated gastric varix. What that is they have bleeding gastric varix on endoscopy. And then when we checked on endoscopy, they have minimal or low risk EVs, esophageal varices, and they don't have ascites. These patients, doing a primarily RTO is reasonable without the need for TIPS. And, the studies have shown that these patients, somewhere around up to 10% may require TIPS down the road for worsening ascites. Now, their EVs can get worse, but these can be eradicated with endoscopy. And, so that's a chance that you take. Now, if they have encephalopathy, then definitely, that is their best option, is just to do RTO alone. Now, on the other end of the spectrum, you have somebody who had bleeding gastric varices. You just go look at it, and then they also have bad EVs, or they have, significant ascites as well, and they have bleeding gastric varices. So that is a patient that would benefit for a combination TIPS and RTO rather than just RTO alone, because it's going to exacerbate their ascites and their EVs. So that would be the type of patient I would do a combination on. Now, there are some other patients that potentially could require it that becomes get a little more, specialized, and you'll see it, more of a transplant center. But definitely it's an indication, which is if you have a patient with portal vein thrombosis, chronic, portal vein thrombosis or acute, so doing a TIPS to open the portal vein and then occluding the shunt. Now they have a good portal vein that they can potentially transplant to. Another one, which is a little bit out there, but we're collecting data on it, which is patients with encephalopathy who have a huge shunt. By occluding the shunt alone, usually that is good enough to improve their encephalopathy. But if they have a really tiny portal vein or no portal vein, you occlude their shunt, they're going to thrombose their SMV and they're going to be in bad shape. So for these patients, I would occlude their shunt, although they have encephalopathy, and place a TIPS. And it's have to kind of, there's always a double takes, like, why are you placing a TIPS for encephalopathy? But, the idea is we're going to embolize a very large shunt and place a smaller TIPS that is more controllable than, like, they end up with a 7 or 8 millimeter TIPS, and then you include a 2 centimeter shunt. So now you replace one bad shunt with a good shunt, and their encephalopathy improves a lot. So these are the combination cases that I would see. But the most common or classic of them would be a bleeding gastric varices with ascites or high-risk EVs.
Okay. And when you do a combined procedure, you do the TIPS first in all of the combined cases?
Yes, I would say I would do the TIPS first. It just helps you with the anatomy. When we're doing RTO, you're doing somewhat blind, like you're injecting against the flow. So you're just, saying where the flow is going to go as you push it against it into the inflow. But, here you're going to be in the portal vein, might as well start with that. So I would just get the TIPS in first, go into the splenic hilum, do a run, and just know how many inflows do I have, what the anatomy looks like, what the shunt looks like, and just have a good sense of what's going on. And then from that point, we'll decide do I do what's called a BATO, like antegrade embolization of the shunt, or retrograde, or both antegrade and retrograde, in addition to the TIPS. So, generally speaking, if you have gastric varices, high-risk gastric varices that bled, or they are high risk now, they haven't bled, to eradicate them, just simply placing a TIPS alone is not going to eradicate it, all right? Simply coiling the origin of that, simply coiling the posterior gastric vein is not going to eradicate these gastric varices. They're going to recruit other veins, short gastrics or left gastric, and they're going to, fill again. So it's been, several studies have been done. We looked at it, there's a couple of studies from Asia. Dr. Gable looked at it from Illinois. And several studies have shown that these gastric varices bleed at a lower gradient. By just simply coiling the origin is not going to be enough. You need to sclerose the shunt itself. You need to sclerose the gastric varices to get complete obliteration. So that's why whether you do that with an antegrade approach by filling it, putting a balloon at the origin of the posterior gastric vein, go up with a micro, sclerose it with STS or gel foam, and then coil the origin. So that would be a very good option. You can put a plug, go next to the plug with a catheter, similar to what you do retrograde, but you just do it antegrade through your TIPS sheet, after you place your TIPS. So I would just go and place the TIPS, get the stent out of the way, dilate it, and then go into the splenic vein and do all the embolization. I find myself more likely than not when I have a big splenorenal shunt, to make the BATO go easier, I go from retrograde, from femoral, and I place a balloon or a plug at the splenorenal shunt origin. Basically, so go up to the axis that we just talked about. You go up in the renal vein, up into the shunt, balloon or plug, pull it back, wedge it, make it stagnant, but then do the embolization from the TIPS axis, from the antegrade, from the splenic vein, get up there. You already occluded the outflow. You have the varices pretty much jailed, and now you can do whatever you want. So now it's easier to do an antegrade because you're closer to the varix. So you can just go from there instead of trying to fight your way backwards. You're cheating now. You're already there. I mean, of course, I'm going to do it backwards because I just like to make it harder myself. But I usually, if I end up doing this way, the fellow complains like, no, let's try to do it because I want to learn how to do it from retrograde. It's like, well, depending on the day and when we started. But
Sure.
yeah, you try to do it antegrade, and then from there, as I said, you have a lot of options. I like STS. I think it works very well. You can use gel foam, but the idea is to sclerose the varix itself and then coil it to decrease the chance of it recruiting other inflows. And then you just remeasure your gradient afterwards, and then you decide on your, how much more to balloon your tips. So maybe you can start with a, 7 or something, measure the gradient afterwards, embolize the shunt, antegrade, retrograde, all that stuff, and then remeasure the gradient. Most likely it's going to go up. Then you can go with the balloon, go up to 8, 9, 10, whatever is needed to optimize your gradient afterwards.
And it sounds to me like you're doing all of these combined procedures as a single day, single session thing. Is there ever a situation where you put a TIPS in, and have them come back and do the BRTO afterwards, or the combined BRTO, BATO afterwards?
Yeah, I mean, depending how long the TIPS took, to be honest with you, and how complicated the access was, and sometimes we've had these portal vein recant for PVT. These can be problematic in a way, and you spend a lot of time getting access. So you have a high radiation dose and such, and then you can bring them back and do the shunt later. If they have recent bleeding from gastric varices or just bleeding now, no, we're finishing all at the same time. But if it's they have, there's a scenario, they have a big splenorenal shunt, no bleeding varices, just big splenorenal shunt, and they have ascites. Right? So, if they scope them and there's no bleeding gastric varices, the reason to do the procedure was for ascites, but they do have a big splenorenal shunt. I would do the TIPS, measure gradient, and see how they're doing. If they're fine and everything is okay and the gradient is reasonable, probably can leave that shunt alone, and then see how they do. But if the gradient is very low, then I'm occluding the shunt to prevent them from having a bad encephalopathy. But the gradient ended up being like 7 or 8 or something. We may just watch them and see and then check. And if they have encephalopathy, you have to come back and then occlude that shunt. And then, to have the direction of flow through the tips. So these are some of the times I would do it as a staged approach rather than doing it at the same time. So it's all these, I think it's a lot of factor, time in the procedure. I would say, I'm trying to think about it, dictates most of the time, how long we've been in the procedure, radiation dose and such, anesthesia time would probably dictate this more than anything else.
Yeah. I guess one of the benefits of doing it all at once too is you have the patient under GA presumably for your tips, and then you can you do the BRTO at the same time. But when you bring back somebody for elective or semi-elective BRTO or RTO, do you do those under sedation or do you do them under GA?
I think sedation is fine. We've done many under sedation. It's depending on anesthesia availability for you. It's just something, all about local environment. Right now,
sure.
The way we have it is we have several anesthesia teams that we have to use and all this stuff. So I'm doing these cases with anesthesia just because of that. But in any other setting, I don't necessarily have to do them with anesthesia.
Got it. I'm sure this has changed over the past 5 to 10 years with the advent of ICE guidance for tips, especially in portal venous reconstruction cases. But can you walk me through a situation where you've had to do antegrade access through the spleen to get to the splenic vein for shunt embolization?
Yeah, so I would say that I have one scheduled tomorrow. So it's it's a lot of these portal vein thrombosis cases, especially if splenic vein thrombosis, where you just your access to the portal vein is going to be hard to do if you have cavernous transformation or you don't have an intrahepatic portal vein to access, then it's a transplantic access. And, we, just can present our data at SIR, hopefully, that, it's having a much lower threshold to go to the transplantic access for a lot of my cases that we spend a lot of time trying to get into the portal vein antegrade. So that I would say is a common scenario that I would do, especially for these portal vein thrombosis. Now, you may end up having a patient with, let's say encephalopathy and a huge shunt that the angle to get to it is better from the splenic rather than from the hepatic axis. It's like a backward turn from the hepatic. But we just access from the splenic and embolize that shunt that way. So that is a something that, we've done. In cases where, I would say you're trying to do a BRTO and trying to go retrograde and you're end up not, and I've had to do this a couple of times where the inflow, I suspected there's two large inflows and I tried to kind of reflux up and it's just not pushing into the varix anymore. I feel like there's more than one inflow coming. These are rare, but they're complex inflow types. And then I would just get into the spleen or transhepatic, either ways, and then basically do a venogram just to see what the inflow looks like to kind of help with finalizing. You can then do a little bit of antegrade and retrograde at the same time if you're just doing a BRTO, not leaving the tips behind. So I had that, a patient with encephalopathy and gastric varices, and we wanted to do BRTO and to block their shunt. Their portal vein was fine, but they just had this big shunt. So did a BRTO, but it was just anatomy was complex. And sure enough, I did transplantic access injected. There's two inflows. So that's why I could not reflux enough into them. So I just used to occlude one, and I used the balloon to occlude one antegrade, and then with the retrograde, I filled both inflows, then embolized on the way out into the spleen and the way out and got out. I could have done that transhepatic, but now we're getting more comfortable with transplantic that, even if I have a stomal varix or something, or, that I need access for, I'm just going transplantic now because we're doing it, much more frequently and it's easier to find.
Can you walk me through your setup for transplantic access and what's made you more comfortable with it?
Yeah, I think the spleen, there's one thing, right? Just the veins, well, there's an artery too, but, chances of hitting that is less, except that a case I did a couple of months ago, we got access, like, the wire's flying, we put in, we injected, we're in the splenic arteries. Like, what are the odds? Really?
I know, right?
Anyways, so that was fun. But then I would say that, you can do transhepatic, but, if you're doing a gun side tips or, recanalization, you need a access the other way around. So that the splenic becomes helpful. Yeah. So, ultrasound guidance, I think just made it much easier. You just look at it and try to find a good angle to get into it. I use an echo tip needle, Chiba Enride, one of these, and then, try to be exactly in the middle of it. It's all about good ultrasound skills. Trying to kind of puff your way here and there, it doesn't work. You have to be smack in the middle of the vein with the echo tip needle in it when you put your wire, because the wire is always going to go. Like I use a nitrix wire, for example, but it's always going to go. It's going to, look at that. It looks great. It's going to like dissecting through the tissue and, go everywhere else. So you have to be, and then you upsize it with an AccuStick or an F-set or what have you. And then all of a sudden you're like in the middle of nowhere. So you need to see your needle in the middle of the vein to confirm that you're there. The more you do it, it's a good skill to have. And this is what we do. We do it for nephrostomies. We do it for, everything else, for non-dilated nephrostomies, for biliary. So we used to do this stuff. And I, I'm going, a lot of times I go closer to the hilum. That's fine. It's okay. It's like, some of the veins, intraparenchyma are harder to get into. And get close to the hilum, it's fine. There's no major issues. You're coiling the track anyway, so it's not a big deal. Yeah, so that's what I use, spend time and just make sure that is the most important aspect of the case, and, spend as much time as possible to do it. Keep telling this joke. I did a workshop for transplantic access in Jordan. That's where I'm from originally. So they kind of lined up two cases for me, and there's a bunch of people in this room came to watch me do a transplantic access. And for the life of me, I could not find a splenic vein. I was
of course.
Great. That's exactly what these guys came for. Eventually we did it, and we finished two cases by 10 p.m. and it was two very long, difficult cases. But, it's just, it sometimes it's very humbling, and you just spend as much time as possible, and you may not get into it, but if you kept cutting corners and trying to push the needle and keep creating full spaces, doesn't help. You just need to be very patient. See your needle in the vein and go from there. And then, I just put an AccuStick and then go from there. If I'm doing a recon, I put an Ansel sheet and do the work from there. And on the way out, I could embolize anything you want. Some people use MV plugs. I use usually coils, like MRI coils with like a lot of, fibers on them on the way out.
Well, thank you for sharing that anecdote, because hearing that you have trouble with cases sometimes makes me feel better. And I'm sure it makes a lot of younger IRs feel better when we're struggling with stuff.
You should see me yesterday. We're recording this on a weekend. Should see me yesterday. Yeah, I had to bring a patient twice because I struggled with the first time around. So yes, the struggle is real.
The struggle is real. All right. This is a really straightforward question, and I think I know the answer, but just to hear you say it would be helpful. Would you do a BRTO on somebody who you know could not get a TIPS, like if they had an HCC or a history of encephalopathy or right heart failure or some other contraindication of TIPS, but they had bleeding GBs?
Yeah, I mean, these are harder. I mean, of course, now you have to have a good discussion. I mean, like goals of care, and what we're trying to accomplish here. But I mean, if they have a bleeding gastric varices that could not get a TIPS, yeah, I would do a BRTO alone. And then, just, to stop the bleeding, or to help them with encephalopathy, if that's what we're going after. And, this comes up frequently.
Okay. Could you please talk a little bit more about your post-op follow-up imaging and when you see them in clinic?
Yeah. So usually you need to get a confirmation that you obliterated the varices. And I usually like to do this within a couple of weeks, up to most, no longer than 4 weeks. I usually do that by imaging. So CT is very good. By the way, for pre-op, I like CT more than MRI. It shows the details. The resolution is better for finding find exactly where the veins come from and such. So that's why I usually, follow up with CT. MRI is more beautiful because when I use Lapidol, it can, kind of block things some, but it's nice to see it. Either ways would work. I would do it around 2 to 4 weeks for that. If it's just BRTO, I'm fine with 4 weeks, just doing an imaging and go from there. And usually they have them scoped within 3 months, and then they get scoped at 6 months and then annually to watch for EVs. So 3, 6, and then 1 year, and then annually thereafter to watch for EVs. If it's a TIPS, generally speaking, our TIPS will bring them back in 2 weeks for ultrasound. So if it's a TIPS plus BRTO, I'll do an ultrasound and CT at 2 weeks, and then we'll go from there.
That's fantastic. I think you've covered most of the stuff I want to talk about. Is there anything else that you would like to talk about in regards to TIPS and BRTO? Any other pearls for us?
Yeah, I mean, I would say portal work is probably one of the most fun work. Sometimes can be one of the most challenging. It's one of these things in IR. Then, there's a lot of overlap with other specialties. There's nothing wrong with it, but it just sometimes can frustrate some younger people when it's like, I would like to do PEs and DVTs, and then these other specialties are doing it in PID and or even ablations or nephrostomy access for lithotripsy and gastrostomies. And you can go down the line, even ports. So just there's most things we do. There's some other specialties that does something similar to what we do. Portal interventions is something that we own as an interventional radiologist, and I think it's good to be really well versed in it as an interventional radiologist to provide value. That being said, if it's something that is you're not comfortable with, it's okay to ask and reach out to other centers or other people around the country who do more of it. And that's something that I would say spend as much time as possible reading about these topics, recanalizing portal veins, how to do a complex, splenic access, how to do a recanalization, when to embolize the shunt, when not to embolize it. I think all the questions you asked, Ali, were excellent. I hope we gave an answer about some of these that kind of help people get started on the right track. But yeah, you can read more about it. There's several articles that were put out there, as a how to and things like that are good. Yeah, just to spend the time and effort to learn about this topic will serve it quite well, because usually as an IR, you're the only hope for some of these patients when there are many other options for them to do. One other thing about just other options for these patients that I'd like to kind of emphasize is there's, the other alternative for EVs is more banding, and can be done. I'm sure you talked about in the previous podcast about the need for early TIPS for patients who had a history of bleeding varices. With gastric varices, the options are limited. There are no banding. So basically it's glue, and glue is the main option there. Most centers around the country are not comfortable with doing glue for gastric varices. So depending where you are, you may have some expert, expert providers who do this for glue. But we did a study comparing, glue and BRTO, and showed that BRTO in several aspects has the upper hand over glue. So it is a good technique that there's not a whole lot of other options for it. And the last thing I want to say, whatever you do, if you have somebody with bleeding gastric varices, please, please, please do not just place a TIPS and coil the origin and then post it on Twitter and put a mic drop emoji or something like this.
Generally frowned upon. Got it.
Just,
Okay.
just
Won't do
generally
that.
frowned upon.
I'm going to
Make
cancel
sure-
my plans for the rest of the day.
Yes, make sure to sclerose the varix, then put the coil. Don't just coil it and then think that you've done all what you need to do there.
Yeah. Yeah. One kind of a clinical question. When you moved from UVA to Georgetown, you were probably one of the only people doing BRTOs up there. So how did you raise awareness that you could provide this new procedure to basically to your referring doctors who probably had never heard of it, was wondering what it was, and were probably cynical that it would work?
Yeah. So, luckily for me here, we have excellent providers who've done it before, other IRs and some of my colleagues who've done it before. So it was not, the awareness was not that, and there's some proximity, and I interacted with some of the hepatologists before. So it was not that, a kind of bigger hill to climb. But we have the hospital center, for example, it was less of an issue. It was more of an issue because it's 2 hospitals that we cover. So for example, the other one, it was a little harder to convince. But yeah, talking to hepatologists was the main way, and to GI doctors. Some of the GI doctors, I was surprised that they have no idea that this exists. So basically, I just gave a lecture to the GI fellows, and to the GI department, and then we did a dinner thing, and I did it also via Zoom afterwards and all that stuff. So I think just that's something that we had to kind of bring up, and how to resuscitate gastric varices, for example, not to keep pouring plasma and blood and load them with fluid, and they keep increasing the portal pressure and they keep bleeding worse. That's not the solution. The solution is to put a Blakemore, stop the bleeding now, and then call me, and then we'll do it. And on that note, just quickly on the emergency gastric varices bleeding, I think BRTO can work fine, and there's a lot of that is in Asia mostly. I still tend to end up getting a TIPS access if the portal vein is open.
Oh,
I feel things can go faster, and I can do a TIPS and BRTO at that setting rather than BRTO alone. If somebody is like bleeding on the table, like there's like
Got it.
Now I've done it before with patients who have other issues, or the portal isn't that great or something, and then I just wanted to do a quick fix. I know several who've done it, and I think it works well. For me, if I think I can get TIPS access, usually it's not that hard to do it if the anatomy is good. I would just get the TIPS and do TIPS BRTO at the same time rather than just doing BRTO, because if things don't work well and all the stuff, and you're stumbling, and it's one of these harder ones,
Sure.
the bleeding patient, you could help them a great deal by decreasing their pressure. So unless they have like bad encephalopathy or something, I usually end up doing TIPS BRTO for emergency acute bleeding with a Blakemore on. I'm not saying that it doesn't work. There's paper about it. People have done it and have success with it, but that's been my preference so far.
Okay, that's good to know. That's a lot of the referrals that we get in our practice. Okay. Well, thank you so much, Saher, for being on the podcast again. Really appreciate it. And thanks for talking to me. It was good to talk to you after a long time.
I know. Would love having you with us as a resident fellow.
Oh.
It's so awesome to see you, this shining star doing awesome work. So great to see you again, Ellie. Thanks so much.
Take care.
Bye-bye.